That's really it for our summary of our 5 white blood cell types, but it always warrants going over twice, in my opinion. So let's go through these real quick. What is our most common white blood cell? Neutrophils. What do? First responders, they use phagocytosis and lysis to break down bacteria invaders' cell fragments. Good. What's next? Lymphocytes. What are the keywords there? Immunity. Specific and innate immunity. We'll learn more about those guys later. Next up, monocytes. They're the big eaters, macrophages. Good. Then what's next? Eosinophils. They're the pretty pink and purple ones, and they help us do what? Kill parasites. And basophils are the very, very dark purple ones, and they do what? Allergies. They release histamine from their granules. Okay, great. And that's really it for those 5. I mentioned earlier that megakaryocytes break off cell fragments that become platelets. So this is what that process looks like. Here's a gigantic megakaryocyte, and these little cellular extensions are breaking off into the bloodstream into little fragments that are platelets. They look like this histologically, although this is not something I will have you identify histologically. And I just realized I'm not using my laser pointer. This is their histology, but I will not have you identify that. You should know that megakaryocytes create platelets. There's going to be a stem cell line chart in just a few seconds, and I will show you which ones are significant in the stem cell chart. There is a reason that I'm going to have you learn that. Okay, hemostasis is the process by which we clot and then hopefully get rid of that clot successfully. The blood vessel is cut for some reason. It got sliced open. The first thing that's going to happen is that the blood vessel is going to spasm and contract. It's going to do that because we do not want to bleed out of a small cut. We want to restrict blood flow to make the clotting process easier. So vascular spasm goes first. Then we're going to start to form a platelet plug. And that is going to be a combination of collagen fibers, fibrinogen, being converted into fibrin and laying these fibers across that gap, and adhering platelets. Platelets are going to adhere to that surface. So that's going to form that platelet plug. And because those things are sticky, things like red blood cells or white blood cells are going to start to stick into that platelet plug. Finally, that fibrin is going to create that mesh, and it's actually going to start to pull the two sides closer together. So again, that fibrinogen was one of our plasma proteins. There were 3. What was the first one of those plasma proteins? Albumin. Good. Do you guys remember the second one? The G1, globulin. Good. And then fibrinogen. So fibrinogen actually has to be altered into fibrin in order to be part of that clot retraction process. You do not need to learn this entire process. I'm just going to point out that there is an extensive process of thrombin and fibrin being converted by various enzymes, and I'm going to point out these guys just for the future. Factor 10, factor 7, there's 10 again. There's a bunch of different factors, clotting factors, and when we get to alterations to hemostasis, when we get to hemophilia, what we're going to see for each of those forms of hemophilia is a deficiency in one of these factors. So every one of these things is necessary for this cascade to take place, and missing any one of these factors, which are all different types of proteins in this cascade, can mean a deficiency of clotting. So that's for the future. Here's a really cool scanning electron microscopy image of a blood clot, showing you that fibrin literally is a very fibrous structure. The platelets that have adhered to it, the erythrocytes that got trapped in this. So after we have a clot, we're going to repair that endothelium, and once that has repaired, we then need to retract the clot without breaking that whole clot off all in one piece. That would be bad. That would be an embolism. That would be a stroke or a pulmonary embolism. We don't like those. So the clot retraction is going to be a process of squeezing it together, drawing it together, repairing the vessel, and then lysing the fibers, fibrinolysis. You have a substance called plasmin that's going to help digest that fibrin. Essentially what I'm saying is we're going to break down that clot piece by piece. Slowly but surely. It's going to go away so that we do not embolize and die. Okay. Among other things, your liver also releases heparin. So you may have heard of the drug heparin before. It's a blood thinner. You have your own endogenous heparin as well. So your blood stream is always trying to balance this out, saying not too much clotting, not too little clotting. We want to clot. We need to be able to clot when it's necessary. When you're injured, we need to be not clotting all of the time, because there are definitely disorders where people clot too much. Okay, I think we're good.
Is that a positive feedback loop then?
So hemostasis was an example of a positive feedback system, absolutely. So this continues until that tissue has stopped bleeding, until that clot is fully formed and retraction is occurring. Absolutely. Good connection. Any other questions before we move on to disorders? Nope. Okay. Do I even have that? I do. Before I move on to disorders, let me show you this real quick. This slide's probably just out of order. You have stem cell lines, and this is true for all of your cells. This is especially clinically significant for us because of leukemias and lymphomas. So you have a myeloid stem cell line responsible for most of your blood cells. And then you have a lymphoid stem cell line that is only responsible for your different types of lymphocytes. So when we get to lymphatic system, we're going to learn about B lymphocytes, T lymphocytes, and natural killer cells. They're all variations on lymphocytes that we learned about today, your innate and specific immunity cells. They have their own dedicated stem cell line that differentiates into these three, which these two also further differentiate. Everything else is the myeloid line. What this means is that if you have a myeloid line tumor, depending on its level of differentiation, if the tumor's here, you could have a form of blood cancer that affects the formation of red blood cells, platelets, monocytes, neutrophils, and what's that supposed to be? A basophil right there. That's not a good representation of a basophil. So you could have multiple effects from one type of tumor if it hits early enough in that myeloid stem cell line. So the only ones that I want you to learn from this table are the myeloid stem cell line, the lymphoid stem cell line, lymphoid giving rise to lymphocytes, myeloid giving rise to literally everything else, and the only other progenitor cell that you need to know here is the megakaryocyte, and you've already heard that because it is the one that forms those platelets. So none of these other intermediate steps, you can safely ignore those. Good? Okay, let's go back to our bleeding disorders. Any questions before I do bleeding disorders? Nope. Okay. So thrombocytopenia means that you are deficient in platelets. Maybe there's a problem with your megakaryocytes, for example. Maybe there's a problem with the myeloid stem cell line. For any reason, if you are lacking platelets, that is part of your clotting cascade, you will have symptoms related to not being able to clot. Petechiae are little spots of burst blood vessels. They especially appear in areas that are rich in blood vessels, like on the nose. And they appear due to spontaneous widespread hemorrhaging. So it's a surface view of something that could very well be systemic. One context in which you will see this is chemotherapy. Destruction of red bone marrow from radiation, for example, for, let's say, leukemia treatment. That's probably your most frequent source for seeing thrombocytopenia clinically. Now, fibrin, albumin, globulin, they were all produced by the liver. So if you are in liver failure, if you have liver cirrhosis, if something else is going on with your liver, you may not be able to synthesize those plasma proteins. If you can't synthesize your fibrinogen, then you're not going to be able to clot very effectively. Your liver just does everything, is what we're going to get from digestive lecture. It's just involved, it's got its hands everywhere. You need it to metabolize vitamin K, and vitamin K is also important to your clotting cascade. So in multiple ways, you're going to have clotting impairment if you have liver disease. So you have factor 8, factor 9, factor 11 deficiencies, each of which lead to different forms of hemophilia. These days our blood supply is fairly well monitored for HIV and hepatitis. So it's not as big of a concern, but back in the day, needing frequent infusions, a lot of people contracted HIV during the 1980s AIDS epidemic because A, the administration wasn't doing anything, because B, they weren't funding research, and research was unable to make a good test for HIV in blood samples at that time. There's a super weird condition called DIC. You ever seen DIC? You haven't seen it yet? It's pretty rare. It's poorly understood why some people develop DIC. There's some kind of trauma, and I'm going to use sepsis as an example of a trauma that's going to affect the entire cardiovascular system. Just because you become septic does not mean you will develop DIC. Some people who develop sepsis, which is a systemic infection, will develop DIC, and this is what that is. Something causes all of your clotting factors to activate all at once. We don't know what, but everything in that clotting cascade is initiated, and everything clots all at the same time. And in the process of using every single protein that you have for clotting all at the same time, then you bleed around every single clot you formed. So in DIC, this is where people are bleeding from their pores, from various orifices, just widespread bleeding. And now you've used up all of your clotting cascades, and it's like you've used every brick that's in that pile. There are no more bricks. You can't clot anymore. You already used all of that. Occasionally occur as a pregnancy complication, septicemia, incompatible blood transfusions. That makes a little bit more sense because we've got that agglutination happening. Again, why it happens to some people in these very, very specific scenarios is not understood. But it makes sense, right? I mean, in terms of the physiology of use all your clotting factors, none left over, widespread bleeding. Good there? Okay, we did myeloid and lymphoid stem cell lines. This word right here, pluripotent, this means that a stem cell can become multiple plural things, right? So when that sperm met that egg, that resulting cell was totipotent. It could become anything. And then it became multipotent. It can become many things. And then it started to differentiate, and then it became pluripotent. And then some cells differentiated so far that they could only become one type of cell. They were unipotent. So I'm just giving you the naming convention for that term right there, pluripotent. And if you have any interest in stem cell research whatsoever, that's some vocabulary that will help you. Otherwise, I'm not really holding you to that information. Isn't that cool, though? Pluripotent. So when we do stem cell research, we're saying, is there a way to turn this cell back into this cell? Is there a way to turn this cell back into that cell? Maybe we need more of this cell, and we can get it from more of that cell. And that's what we're doing. Okay, because red blood cells are responsible for oxygenating us, if we are low in red blood cells, that leads to hypoxia, low oxygen. If you have too many red blood cells, that increases blood viscosity, and increased blood viscosity can lead to clotting. and we do not like too much clotting either. So we really do need to balance red blood cell production and destruction. Now, do we remember the hormone that initiates red blood cell production? Erythropoietin. Yes, well done. EPO. Group effort.
That sounds right.
Yes, that was good. And it's from the kidneys. So that's one of the things that is a hormonal control for red blood cell production. And then nutritionally, you need everything that goes into red blood cell production, including iron, enough proteins, so amino acids are the building blocks of proteins, and a variety of B vitamins. Being short in any of these things can lead to anemias. Now that erythropoietin comes from the kidneys. What if you're in kidney failure? If you're in kidney failure, you're not secreting erythropoietin, you're going to have a hard time producing more red blood cells on your own. What's that?
And then dialysis?
Yeah, so the dialysis is going to help with the filtration functions of the kidney. It's not going to help with the red blood cell production of the kidney. So you're going to have to get EPO injections, yeah. And we do have synthetic EPO. That is a thing.
Okay, so you have.
Yeah. It's also what athletes use to dope their blood.
Oh, okay.
Yep.
So what?
So one form of blood doping is to inject yourself with EPO, and then you have more red blood cells, which means you have more oxygen carrying capacity, which means you can run further, faster than ever before.
Or they just come to Denver.
Is there such
Or
thing
you
as
just come to
too much?
Denver. Yes, there is definitely such a thing as too much. What happens if there is too much?
Oh, right.
It clots. Yes, it increases blood viscosity. So that's what athletes are risking when they dope with EPO, is blood clots.
Can you check that with like an INR?
I don't know that they use an INR. I think if they're blood doping, it does show an abnormally high level of EPO that is detectable. That is feedback I've gotten from students when I was asked that question, did not know the answer. So. Okay. Anemia can be from blood loss. You get stabbed, you lose a lot of blood, now you're anemic. You can have chronic hemorrhaging. Some people will just have hemorrhoids or a bleeding ulcer for a really long time and let it go unchecked. And they have slight but persistent blood loss, and that can cause anemia too. Treat the hemorrhoid, treat the ulcer, you'll be fine. Iron deficiency anemia. Basically, women who menstruate are going to have iron deficiency anemia all the time. Not really, but some people do have a monthly cycle that involves iron deficiency anemia because we lose a lot of blood through menstruation. So if you are a menstruating female, consider like a cast iron skillet, because that actually works, or iron supplementation, but you know, cast iron skillets are nice because you buy them once and they last forever. Pernicious anemia is going to be one in which you lack vitamin B12, therefore we cannot form red blood cells. Vegetarians are especially prone to developing a B12 deficiency. So sometimes, you know, a vegetarian will go and get a B12 shot and they'll be like, wow, I feel great. Have you ever gotten the B12 shot? No? You should try it. Actually, that's when I taught in the acupuncture campus, a lot of the students I taught were vegetarians, and they actually had a day where they taught them to give B12 injections by injecting each other with B12, and they were all like, I feel so good! It was hilarious.
Is there an anemia?
Probably. I can find out. Remind me about it, and we'll look at it.
I had to get a shot of riboflavin.
It's probably riboflavin. Yeah. I think riboflavin is a B vitamin. I don't know if it's B12. It probably is. We'll look into it. All right, renal anemia. That means that you are not secreting EPO. Often accompanies renal disease. We can treat with synthetic EPO. Aplastic means that the red bone marrow is destroyed or inhibited. Probably, again, most likely cause that you'll see is chemo and radiation. And hemolytic anemias, again, remember, part of the life cycle for that red blood cell is that it has to be broken down by the spleen and liver towards the end of that 120 days. It's defective, right? It is possible for your spleen to go a little hog wild and break down a whole bunch of red blood cells all at the same time, especially if they are all defective. If you have sickle cell anemia, the reason that you're anemic is that your sickle cells your cells have collapsed in on themselves because that hemoglobin is defective, and that hemoglobin is a structural unit. They become sickle-shaped. Your spleen sees that and says that's no good, and it destroys it. But that happened to a whole bunch of red blood cells all at the same time. So those all go to your spleen at the same time. They basically clog your spleen, and then you become asplenic because you've damaged your spleen by overloading it with sickle-shaped cells.
So why do you die from... there was a girl in high school who I was friends with who died because she had sickle cell.
Yeah, you can, if with untreated sickle cell disease, you can absolutely die of it. There's the hypoxic aspect of it, which is obviously rather big. For chronic patients, there's a big pain aspect to it as well. And there is becoming asplenic and being more prone to infections that can also result in death.
Okay.
Yep. Yep.
The spleen is glandular, right?
No, it's part of the lymphatic system.
Okay.
So it's not quite glandular. It's kind of a spongy structure to it. It is, we'll talk about it quite a bit in lymphatic. It's got these sinusoidal blood vessels that allow for giant blood cells to come in and out of capillary beds and into these nodes within the spleen, these pulpy places within the spleen, where cells will phagocytize those red blood cells.
Is it innervated?
Yeah, I mean, it'll respond to innervation.
I'm just
Everything's
trying to
innervated.
figure out what it's pain.
Oh, for pain for the spleen? Yeah, it's going to be a visceral pain.
Oh, okay.
It's going to be visceral just like the rest of your intestines and liver and all that. All right, so again, for example, sickle cell anemia, abnormal hemoglobin, results in fragile red blood cells that will lyse prematurely. They'll be broken down prematurely, and that leads to literal low red blood cell count, which is an anemia. Sickle cell anemia definitely travels in very specific genetic lineages, especially people who live in very hot environments where malaria is common. That includes much of the continent of sub-Saharan Africa and also places like India. So genetic lineages from those places will be more likely to carry sickle cell disease. It does kind of make it into a racist disease, and I don't just say that because it's affecting people with certain skin tones. I'm saying because now there are medical tests that only people of color will be responsible for paying for, unless we make everybody do it, even people who are not prone to it.
She was African.
What's that?
The girl who died, she was black.
Yeah, it's much more common in that community, yes.
So when you're talking about asplenia, that's only like what you're talking about is if they have to have their spleen removed because of, or is it somebody
I don't know if
born
they
without?
necessarily remove the spleen. Once the spleen is sufficiently damaged, we consider them asplenic for immunological purposes.
And what if somebody with just they
If
just
you
did
were
not have
born,
one?
yeah, if you were born without a spleen, you're still asplenic. If your spleen was damaged, then you're asplenic. There's a lot of things that we call asplenic, which I learned from a case study in patho, by the way. Yeah.
And what about polysplenia with multiple little spleens?
Yeah, that's a weird thing. I think they'll still largely be functional unless there's a different disease state, as far as I know. Okay. Any other questions? Nope. Okay. So thalassemias, I brought that up because this says typically Mediterranean ancestry, and I wanted to explain some of those genetic lineages that are happening with these blood disorders. Again, this is just another form of deficient hemoglobin. Sickle cell anemia is about hemoglobin type S. The reason sickle cell anemia persists in those genetic lineages is that having the sickle cell trait, only one copy of the affected chromosome instead of 2 copies of the affected chromosome improves survivability of malaria. So malaria is actually a single-celled parasite that infects your red blood cells. And if you have sickle cell trait, you are much more likely to survive malaria than if you have no trait, or if you have malaria, obviously you're very sick in a different way entirely, but you are more likely to survive malaria. So that's why it persists, even though it seems like it would not be evolutionarily beneficial to be in pain all of the time, to be destroying your spleen all of the time. It persists because it helps people survive malaria. This is the literal sickle cell shape of sickle cell anemia. It's due to a single point mutation in the genetic code. It only takes one. That's it. We finished. Any questions before I end the recording?